Well, welcome to this most recent episode of the Akkad and Coca Report. Today we have the pleasure of having Joel Topf with us. Joel Topf, otherwise known as at Kidney Boy, is here to talk about the most recent executive order that came down from high on the mountaintop, I think a couple of weeks ago. Uh, Dr. Topf is an incredibly distinguished resume. He is a practicing nephrologist in private practice at the moment. He went to Wayne State Medical School, 91 to 95, then went to Indiana University for his internal medicine residency. Subsequently, did a year of transitional critical care, pediatric critical care transport. Is that right?
Yeah.
And then from there, you after that went to the University of Chicago and did a nephrology fellowship. Started in private practice and have been in the same place since. In the around the time in between, I guess, right before starting the nephrology fellowship, Dr. Topf started a blog, and from there developed quite a massive presence on social media, and is one of the must-follow accounts for not just nephrology but any medicine on Twitter.
Thank you.
So we are super pleased to have him here. He's here not in the capacity of an excellent nephrologist. He's here, which he is. He's here to talk about the role that he's played, or he's here to actually inform us of what he knows about the executive order and how it came to be. He is sits on a advisory council to the American Society of Nephrology, and in that capacity found himself, by the at least near the seat of power in Washington D.C. Last week. He does not speak for the American Society of Nephrology. He's just somebody who advises, sits on an advisory committee for them, and other than that, some disclosures that. Why don't you tell me some of the disclosures before we start off?
Right. So the first one is I'm on the Media and Communications Committee for the American Society of Nephrology, but I do not speak for them. And what I'm going to talk about is just kind of my own personal opinion and view on what happened last week. I'm also, like a lot of nephrologists, in a number of joint ventures with Divita, where we own, I think it's 5 or 6 different dialysis units where our patients receive dialysis, and one vascular access center where our patients get their permacaths placed and AV grafts maintained.
I see. Alrighty, excellent.
I'm a definite stakeholder here.
That's good. I like having folks that have stakeholders that are stakeholders. I mean, there's some, I think there's some skin in the game when you are a stakeholder. Too often, especially in health policy, I find that folks that have no ownership, no stake, are very free with a bunch of different ideas that at the ground level don't seem to make a ton of sense. So hopefully you'll inform us from that view, which is great. So tell me what's wrong with nephrology as it, what's wrong with the status quo of nephrology?
Okay, so let's rewind a little bit and let's kind of just talk about how nephrology is different from the rest of medicine. Okay. Is that in 1972, Richard Nixon signed an amendment to the Medicare Act and essentially provided socialized medicine for dialysis and dialysis only. And this was at a critical juncture in nephrology in which we had the technology to provide dialysis, but there was very little breadth. Very few people had access to it, even though we had technologically achieved the ability to provide dialysis. And there were literally death panels in which people that were developing end-stage renal disease would plead their case in front of a group of people, usually white men, who would then go back, discuss, and say yay or nay, this person provides enough benefit to society and we should provide dialysis to that person. And if they said no, you would just die of uremia. And there was a very important cover article in Life magazine about these death panels. And it was abhorrent to Americans, right? Nobody wants this, right? This is exactly what Palin was talking about during the ACA. We don't want these death panels. But these were, in this case, this is exactly what they were doing. And so, it was a very dramatic thing. There was a gentleman received dialysis in front of Congress to demonstrate the procedure during the debate on this. Pretty exciting stuff. But essentially, they pass an amendment, and everybody who needs dialysis gets automatic Medicare, and Medicare will pay for dialysis after some odd number of days on chronic dialysis, 90 days or so. And this is, at the time, dialysis was tiny. Very few people were on dialysis. But once there was a guaranteed revenue stream, supply expanded dramatically. And now we have 400,000 people on hemodialysis in the United States, another 100,000 with kidney transplants. And it's sucking up a tremendous amount of the Medicare budget. And one of the other real criticisms about it is, like a lot of medicine, is doctors are paid for providing a procedure. Providing the dialysis is how doctors get paid and how the dialysis companies get paid, but not for really providing value to the patient, right? It's just a fee-for-service type of model. And you have a system where physicians, nephrologists, the more dialysis patients they have, the better their income, right? Like not a bad proxy. If you want to get an idea of how successful a nephrologist is, just ask him how many dialysis patients he takes care of. And as that number gets north of 70, 80, 90, 100, he's going to have a much better life, much better, much higher income. That really becomes one of the most dominant way the nephrologists make money. And you can imagine the perverse incentive there, right? As a patient's GFR declines and they get closer and closer to dialysis, there is a financial incentive to pulling the trigger and putting that patient on dialysis, because they all of a sudden will cross over a very bright line for the federal government, and there'll be what they call the MCP payment every month for taking care of that patient.
How much is that payment about per month?
It's just under $300.
Okay.
And that's, you have to see patients 4 times to get that full amount.
That's separate from the amount that the dialysis unit is.
That's just the professional fee. That's right. And actually, I don't know exactly what the amount that the dialysis units get.
Okay. All right.
Right, but so you see, there's this perverse incentive to get them on dialysis, and then a perverse incentive to keep them on dialysis. Now, one way to keep them on dialysis is keep them alive. That's great, but another way is not letting them get a transplant. Right? Once that patient gets a transplant, they're no longer getting dialysis, and that income goes away. Right? And you can try to make it up by taking care of them in the clinic afterwards, but taking care of patients in clinic not nearly as profitable as taking care of patients in the dialysis unit, just because all the costs associated with the nurse, the facility, all that's taken care of by a facility fee, but you don't get that facility fee for just seeing patients in the office. And so, that's why really the best way to look at income is to just measure the number of dialysis patients. I have no idea how much these perverse incentives actually result in more people on dialysis. Right? I'm sure it happens to some degree. I will tell you that I have never done that, right? And I'm sure every nephrologist would swear to God that they never did that. But I think incentives matter. And when you have this type of system and people look at it, they're like, that's just not how it should be. We should be paying people for health. We should be paying for people for success, right? Providing dialysis.
But
go on.
But Joe, I mean, there are many different analogies to this in other fields, of course. But as a practicing cardiologist, you have a sense of how much the system is being, if not outright abused, but how much it's being wiggled with. Do you have a sense in terms of other private groups, in terms of how prevalent this problem is? Because I can tell you, I know almost every cardiologist in Philadelphia, which is a pretty large metropolitan area, and I can tell you, I can give you a reasonable percentage of how many folks run stress mills, where you have folks that are getting stressed X amount of the time, or folks are coming in and getting 5 different vascular scans, right? So do you have a sense? I know everyone denies it, but do you have a sense, being in the community, of how much this is happening?
Yeah, every nephrologist has a story of a patient who switches units, and all of a sudden they get a new nephrologist, and you look at the patient, and you're like, you don't need to be on dialysis, and you get them off dialysis immediately. And there's cynics that say, oh, that person was just using them for monetary gain, and then there's always alternative possible explanations. What I would say is, I think I've seen it, and I think it does happen. And I would even say that if you look at the literature, rates of transplant in for-profit dialysis units are lower than rates of transplant in not-for-profit dialysis units. And that's pretty damning, right?
Yeah. How different are they? How different are the rates of transplant, would you say?
They were significant and measurable, and something that you would not just statistically significant, but a clinically significant difference. And honestly, I don't remember the exact percentages, but it was enough to go, ooh, that kind of stung.
All right. So that's one. Would you say that's the major problem in terms of promoting this chronic disease state, and not necessarily promoting promoting health, as you're saying? Though the other thing that comes up then is that, there's a rate limiting step, right? It's not like there are enough kidneys to go around.
Well, so there's 2 ways to skin that, right? Yeah. So there's dialysis, and getting them off dialysis with transplant. But the other side of that is, can we do more pre-dialysis, right? And one of the things that they want to do is one of the things that the executive order establishes is a monetary system not so dissimilar to what you have for dialysis patients, but for people with advanced kidney disease with GFRs less than 30. Translation for people with down to their last third of kidney function, last 30% of kidney function, providing a capitated payment to provide care for those patients to prevent them from going on dialysis. So what you're removing there is that bright line between not on dialysis and on dialysis, that there'd be payment for both of those. Does that make sense?
Yeah. So there's basically some in the executive order. So go ahead. Why don't you give me tell me, in your words, what the executive order actually says? So
the executive order it's sprawling. It covers a lot of different aspects. Right. No, and so a couple of things. So one, you said, well, there's just not enough organs to go around. So that's a super important issue. And so there are 2 aspects of the executive order that focus on that. One, living donors incur costs that are not reimbursed. In fact, it's illegal to reimburse living donors for some of these costs, missed work, et cetera. And so the executive order is going to allow that, is going to remove that ban. So these patients that are not patients, these wonderful people that decide to donate an organ to a loved one or to a friend, if they have to miss work, they can get reimbursed for that. And that before, that had been forbidden because they were worried about people paying for organs. And they were so terrified of that possibility that they ended up harming the people that we should be rewarding and be treating as heroes. And so that's going to be one thing. And I guess when Israel did a similar thing a number of years ago, they were able to quadruple the number of living donors. And so I have no idea if that's what kind of response that we're going to get, but this is something that we've been really pushing for a long time, to just treat these people as the heroes that they are.
Okay. So, and that means specifically attaching dollars to what they're doing.
Right. But specifically to cover the costs, travel costs, right, missed work, those types of things.
Right.
And then, so that's living donors. And then there's concern about these organ procurement organizations, that that the way the numbers have been set up, they've been encouraged to just donate the very best organs, right? They just, because they really look at their 1-year success rate, and so if it's a kind of a marginal kidney, let's not transplant that kidney because it might not work out so well, and that's going to look bad for us.
Okay.
And this is the perverse system, right? There's a lot of patients on dialysis that like, give me that dinged up kidney, I'll take that rather than go to this dialysis 3 days a week.
Right.
Very high mortality rate. I'd much prefer to get the kidney transplant.
Okay.
And so what they're going to do is they're going to rework the way that these organ procurement organizations, they're measured. And a lot of it has been a lot of self-reporting and self-analysis, and that's going to go away. And it's going to be a much more simplified system that's going to look more critically at what percentage of those organs that are possibly used are actually used.
Okay.
That's going to push more cadaver organs. And people are talking, you read some of these numbers, some really crazy numbers, like tens of thousands of additional transplants might be available if you start using these organs as effectively as we could.
I see. And sorry, and did you say that so they're going to take away this metric of,
they're going to change the metric. They're going to prevent the OPOs from creating their own metrics. They're going to have a much more simplified system, much more transparent, and hopefully the idea is that that's going to result in more transplants.
Okay.
More organs available. Right?
Okay.
And again, it's a situation of perverse incentives, right? If you just on successful transplants, but not absolute number of transplants, you're going to get fewer number of really well done transplants. And our transplant rates are, the technology is amazing. You're 95% success rate at a year. It's incredible.
Yeah.
But maybe we should be shooting for 85%, but 3 times as many transplants.
Right. Yeah, right. I understand. So of course, every metric has its own problems. So if you take away some type of success metric, then, maybe you end up, maybe you end up transplanting. I guess it comes down to what the successful transplant rate is. And I guess on net, it seems if we're right now at a success rate of 95%, we have a ways to go before, we're really talking about a problem.
Right. The comparison, remember, is dialysis has somewhere around a 20% mortality per year.
Right.
And patients with a failed kidney transplant, they don't die; they go back on dialysis.
Right.
So that 5%, that's horrible. We don't want the kidney to fail, but it's not. They're not dying, or a few. It's not innocuous. It's a real procedure.
Right. So this seems like a a general win, not too controversial. This is something you guys have been pushing for a long time. What can I ask you? This seems so non-controversial in terms of using more organs. What was the?
I wish I have understood any of that. I have no idea, but we've been pushing for a lot of these, and a lot of these things that we're talking about are not new ideas. These have been kicked around among people for the word that I got when I was at the ASN headquarters. They've been working on this for a decade.
Okay.
Over multiple administrations, really focusing on this, and for whatever reason, Trump said, "Let's do this," and he got it. I don't know why. Remember Melinda was in the hospital.
Melania.
Excuse me, Melania.
Melinda may be one of his ex-girlfriends or wives. Hard to keep track.
Likely, there's a Melinda there somewhere. But Melania was hospitalized for some kind of nondescript kidney issues a year ago.
Right.
And Alex Azar's father received a kidney transplant, and at the signing of the executive order, Secretary Azar came out first, and he spoke pretty passionately about his father's journey, because he started on dialysis and then he ultimately got a transplant, and just he lived it as only a son could live through that type of thing.
Right.
And you wonder, those kind of autobiographical things, are they the kind of things that he listens, and so. There were some interesting stories that were told. One of the other aspects, and this is not part of the executive order, but something that they're going to push for, is so I said if you're on dialysis, that's covered by Medicare, but a transplant is not part of what Nixon signed in 1972. Right? Transplant was in its infancy then, and 3 years after your transplant, Medicare stops paying for your anti-rejection medicines, and we as nephrologists, we kept saying this is insane, right? Patients lose the ability to protect their kidney. They lose the kidney, they go back on dialysis, and then you pay for it again, right? Then it's covered again by Medicare. Why would you just pay for the damn transplant meds? And And one of the problems with trying to make what sounds like a totally intuitive, easy argument to Congress was we didn't have any numbers. We couldn't tell you how many people it was that this situation happened. We just had anecdotal data. And when this was explained to Azar just by fiat said, I want this data on my desk in a couple of weeks. And the Health and Human Services was able to generate that statistical information. And now they have that ammunition, and going to Congress will be much easier. And so, once you have the ear of the secretary, things can get done.
Yeah, it's remarkable. So that's one, increasing the number of organs that can be transplanted.
That's right.
Another one was, as you mentioned, preventing progression to kidney disease, right? But that was kind of vague. What exactly are they proposing? How are they going to do that? Or
right. So it's a couple things. So one is going to be they're going to provide a payment for taking care of these patients with advanced kidney disease, and so it's going to remove this perverse incentive to start them on dialysis, because there's a payment before and payment after. That bright line between the two goes away.
So a monthly payment to people with advanced kidney disease, is that right?
For taking care of patients with advanced kidney disease. That's right. Okay. And so that bright line goes away. And then, and it's going to be contingent on when those patients start on dialysis, they're going to be not going to in-center dialysis, but doing home dialysis, right? We have 95% of our patients that are getting dialysis in-center 3 days a week.
Right.
And if you talk to patients that do home dialysis, they tend to really like it. It gives them a lot more independence. And this is something that is very popular in some countries. Hong Kong and Mexico come to mind, and underused in the United States.
So why is it underused in the United States? Are we technologically behind, or what's the deal?
Well, one way to increase it is not provide in-center dialysis, which I think is largely what happens in Mexico and Hong Kong. Right, when there's no other alternative, people will go to do home dialysis. And then you have situations where there was for a long time presumed financial incentives to do in-center dialysis, and I don't know if that really is the case or whether that's really myth. But home dialysis has definitely fallen out of favor in the United States, and to the point where nephrologists are not even trained adequately in the system. And once you've kind of lost the art, then it's really difficult to start it up again.
Yeah, so I gotta point out that this is where it seems so intuitive that we want to help people. We don't want death panels. We want to be able to, if people need dialysis so they can live, we want to be able to provide that. And certainly rich nations aren't happy at all sitting around without a plan for folks, correct? But the moment the federal government starts stepping in and starts supporting and subsidizing certain things, it really, really, really changes the arc of what may have happened if the government had not stepped in. So, you wonder if Nixon coming in and covering dialysis in the way they did, and then the problem always seems to be is that these top-down approaches are relatively, they're not nimble enough to change as technology changes or times change. And so you wonder if, as you're saying, maybe the big reason why are we behind in Mexico and Singapore is because we have this massive government subsidy that focuses on center-based dialysis. So, it makes you I don't know, does it give you pause in terms of wondering about how heavy the hand of government should be? And
right. Well, I think there's no doubt that the history of dialysis is completely carved by the fact that there's this huge government program. I think that's disputable. Right. Like, of course, that's why now we have 400,000. Right, it's paid for. Right, and so. And I think there's an aspects of the way it's paid for that has limited innovation, right? Yeah. So there's something called a bundle payment that the dialysis companies get an X amount of dollars per month to provide the dialysis. And that has to include the medications and the procedure and the tools and the labor, everything. It's just a set amount of money, and they got to provide that dialysis as cheaply as possible. And if you have a new drug and something new, innovative to improve the lives of patients on dialysis, and it's part of that bundle, you're going to have a hard time convincing dialysis companies to just accept that cost, just to eat the cost rather than give that money to their shareholders. Right. And so that's a perfect example of creating an incentive system that blocks innovation.
Right.
Right. And so another aspect of this executive order is to try to improve dialysis technology itself. And the American Society of Nephrology was a stakeholder in a program called KidneyX, which is a partnership between ASN, private enterprise, and the FDA to speed the development of new technologies to help dialysis patients and get it through the bureaucracy of the FDA and get these approved. And it's pretty new. They had their first winners just a few months ago, and these are kind of new ideas. And it's pretty interesting to see what engineers are coming up with. And the big incentive here is you're going to be able to speed through the FDA. And part of this executive order was recommitting to this KidneyX initiative to try to improve. And they specifically pointed out to synthetic kidneys, essentially wearable artificial kidneys. And that's it's a brave new world. We're really, from the data that I've seen, it's not around the corner. It's not real soon, but they're making progress on this. And
again, initially there are two major dialysis.
Two companies have about 80+% of the market. There's Divita, which is what we're partnered with, and another company called Fresenius, which is
Fresenius and Divita.
Yeah.
And so initially, when the executive order was heard about, the stock prices of those two companies fell.
That's right.
And then when the executive order came out,
they rallied.
They rallied. So, it makes me, as the little guy, it makes me worried. Is what's good for Fresenius and Divita good for the dialysis patient?
Well, I don't know. I think what the executive order has is a lot of carrot and not a lot of stick. From what I can tell, is that and one of the things that people I think are pretty excited about is there's these payment models, and I touched a little bit about it when I talked about paying doctors for taking care of patients with CKD stage 4 and stage 5 prior to dialysis. But there's also these payment models for taking care of patients that are on dialysis, and if you can provide savings for providing their care, you can. Some of those savings go back to the in fact, up to all 100% of those savings come back to the person providing that care. And so those at-risk companies that have large enough scale. But clearly, there are definitely some of these payment models that are not directed towards Divita, not directed toward Fresenius, that are really directed towards individual nephrologists. For example, we talked about the perverse incentives for not transplanting your patients. Well, the way they're going to fix that is there's going to be a bonus payment. You get a patient transplanted, and they're going to give you significant payments year 1, year 2, and year 3. So if that patient can survive 3 years with that kidney without going back on dialysis, you're going to get a huge payment.
And that goes to the nephrologist, or
that goes to the nephrologist.
Ah, I see. So how does that benefit Divita?
I don't think that's not an example of something that.
So that would seem to hurt Divita, right? Because you get all these people not being dialyzed, correct?
Oh, right, but there are other models that are focused on them.
I see. Okay, in terms of care, yeah,
and a lot of that is moving towards home dialysis. Right, home dialysis is not dialysis that doesn't require a provider. You still need nurses, infrastructure, training, etc.
So it's going to be Divita and Fresenius that are probably going to be doing a lot of this home dialysis, and there's going to be payments that are attached to.
And there'll be payments and incentives and awards for those companies. That's right.
I see. Okay, excellent. All right.
And it's not that there's no stick. There are some penalties if you're falling behind in terms of providing your home dialysis, which is the large one, and transplant. You're going to get penalized.
I see. So tell me about this the ETC mandatory program. For folks that are listening, um, a lot of this, a lot of the payment innovation stuff or the payment change stuff is kind of done through the auspices of a bureau. It's part of CMS. It's called CMMI, the Center for Medicare and Medicaid Innovation, and that was actually something that came about. It was conceived as part of the ACA. It was given a budget of $1 billion a year, and basically the goal of CMMI was to create innovative payment models that essentially broke the back of the traditional payment model, which is fee for service. And fee for service is, the more volume you do, the more money you make, and everyone and their mom thinks that that's the major thing that was wrong with healthcare prior. And so the question was, how do we pay for something other than just volume? And that's where CMMI was supposed to step in and do it. And CMMI was given the power to create these to change payments as they saw fit and create these different models.
It really is. It really is an amazing amount of power without congressional oversight, right? Because when people explained it to me, because it's Medicare money and it's automatically deducted from the budget, doesn't need to be approved every year by Congress,
right?
And by fiat, they're creating this new model, which is dividing the country in half. Half the dialysis patients are going to be in this ETC model, and other half are going to be the control group.
Yeah. Tell me more. What is that? What is the ETC mandatory program?
So this is not going to be applied to individual nephrologists. This will be applied to the big dialysis companies.
Okay.
I'm pretty certain of that. I'm pretty certain of that. And it's and it's going to incentivize, or it's going to really essentially, it's going to measure your rates of home dialysis and transplant. And you're going to need to move those numbers, or certainly not fall behind what you were doing before. Hopefully move ahead of people that are not in this, that are in the control group, and get more people home. And if you do, you'll be rewarded. And if you don't, you'll be punished in terms of the fee that comes in. More money will be given to you in the CTC, which stands for end-stage renal disease treatment choice. I believe that's what it is. The E in ETC is another acronym.
I see. So, any concerns for how that model is set up, or?
Well, as a scientist, I'm not a scientist, whatever, I'm a clinician. But as a clinician, I prefer to make decisions after the randomized controlled trial to test a small group of people and see if something works, and then implement it widely. And that doesn't seem, that's just not how social programs are done. We draw them up on paper, and if it looks pretty good, we implement them. And so, of course I'm concerned. I don't think anybody knows if this is going to work, right? Is it going to be worse? I don't think it's going to be worse. I think it's improving the incentives. I think they're good incentives, but I don't know. I'm just from just experience with what CMMI has done in the past. I'm not hugely confident in their abilities to come up with models that pay for value. I think they've failed miserably paying for value over and over and over again. I don't know much about this particular space in terms of what exactly they're going to do or how exactly they're going to measure things. But I really hope that someone up there knows what they're doing, and that they're thinking of unintended consequences that may result of some of these things. Have you had a chance to read any of the stuff in terms of? I've looked through it. I wouldn't say that I've been a student of it.
Does it seem like this is something that there are some mom and pop dialysis stores that are still around, correct?
That's right.
How will they do with all of this stuff? Is it going to be hard for them to meet the regulatory requirements? I guess there's a lot of stuff we just don't know right now. But what's your general sense?
I would say that even mom and pop dialysis units already work in an environment with a lot of regulation and bureaucracy. Like, I don't think it's a situation where they've not been touched by the government at all. I mean, they've been really dependent on Medicare since their inception. And there's a lot of oversight there. And what they're measuring is not complex. We're talking about patients going home and doing dialysis at home. And you're going to have to, if you don't have a home program, you're going to have to staff up and develop a home program.
But don't you think, Joel, that this is, again, I haven't spent a lot of time thinking about the dialysis world, but from certainly the heart failure stuff that they've done, don't you think this will affect the folks, like the safety net hospitals, right? The folks that take care of a primarily indigent patient population that have a poor, low socioeconomic status. I mean, how those are groups, I bet you, that are going to struggle to transition to home dialysis in terms of infrastructure support, et cetera, right? So the folks that'll do great will be the folks that are set up to do great, and that will maybe it clearly sounds like it could be the richer zip codes that the hospitals are in, right? So I assume they'll come up with some type of risk adjustment, but it seems like they've failed miserably.
The risk adjustments I've seen, I have not. Maybe I just missed it. I don't remember seeing socioeconomics class. It was mostly focused on patients that were demented, patients with acute kidney injury, patients with, I think it's super advanced age, like people that clearly wouldn't be able to do home dialysis.
Right.
But what you're talking about are super important things. Like, it's hard to have someone go home and do dialysis if they don't have a home, right? Or they live in a trailer that, with 6 cats. Thinking of a particular patient, right? Like, it can be difficult, and those home choices are not. Yeah. They're not as open as we'd like for all patients.
Yeah, so I hate to be too big of a downer in terms of CMMI payment innovation models, but it sure seems like the history of it is that it's affected folks that are the least able to take a hit when it comes to safety net hospitals that take care of what can be a very challenging patient population to take care of. But and the one thing is that it feels like once. The hospital, the heart failure hospital readmission program that I've spent a lot of time reading about and writing about, it seems like these are essentially innovations, payment reduction programs that are disguised as innovation. And once CMS is saving a lot of money, regardless of the fact that the program may not be working as it originally intended, the program just keeps going. Like, there's no shelf life to these policies that come out. So I hope there will be some lessons learned from what's happened before, and brakes applied where needed.
Yeah, these at least from what I understand, these all have a
shelf life.
A shelf life. It looks like it's 3 years plus an extension of 2 years possibly. So we'll see.
Excellent. The other stuff. Were you surprised that this happened so quickly?
Yeah. Like I said, we've been working on this stuff for 10 years, and the fact they gave us it was like everything came out. It wasn't just like one or two things. Like it was pretty comprehensive. Yeah, shocking.
And do you mind if we spend a couple minutes talking about what was the reaction to the news on social media and elsewhere?
Well, among the people that I tend to follow on Twitter or follow me, not a lot of big Trump fans, and so a lot of suspicion and a lot of negative pushback on this. A lot of suspicion that this was just trying to make himself look good and try to get improve his standing for re-election, and not a lot of depth there. And then a lot of suspicion that this is a promise that'll never get executed. And so, so it's funny. I mean, we've been begging and asking for these types of projects for 10 years, and then you kind of get them, and all of a sudden people have kind of turned the other way and are rejected to some degree.
Yeah, it's unfortunate. I think what folks don't realize is that regardless of, the CMS has a massive problem. CMS has a solvency problem, right? And the things that, every CMS administrator that comes in, they are their major task, not something they publicly say. The public faces, increasing health, blah, blah, blah. But very much their job is to figure out how to keep CMS solvent for as long as possible. And I think whether it be a Republican administration, Democrat administration, libertarians, or whoever comes down the pike in 2020, I think they are all incredibly concerned with reforms that are hopefully going to save CMS dollars. And so, I'm not surprised that these kind of things are taking place. I think when it comes to healthcare, I think politicians are remarkably one note, if you will. I think the folks that are the true rugged free libertarians, Dr. Akkad is unfortunately can't make it and be with us today. He would be the voice of this. But there are very few politicians that are dancing to the tune of reducing significantly the government imprint in healthcare. Whether it comes to pre-existing conditions, whether it comes to some type of universal healthcare, whether it comes to some type of backstop for kidney disease, etc. I think everyone has to answer to the community, and the community vastly, the local community, national community, etc. Vastly want this to be taken care of by someone. So. But it was certainly interesting to see how I think this same news in a different administration would have been received in a much different fashion. Though some of it is certainly understandable because there's so much skepticism and concern about the legitimacy of what this particular administration says. But I said it on Twitter, and I'll say it to you again. Kudos to you for kind of sticking to the leaving the partisan politicking for other folks and kind of sticking to what was said, what Secretary Azar was saying, and what the needs of the nephrology community have been, and what the administration, regardless of who it is, what they were doing to respond to it. So it seems like at the very least, they're responding to concerns of the ASN, which on the face of it isn't a bad thing. Though I have some concerns about how exactly they'll implement it.
Yeah, I mean, I think if nephrology rejects this, right? This is just this huge opportunity. Like, if you don't grab it now that it's been offered to you, you're never going to get it again. Right? You've been asking for it. They've changed the rules. The executive order has been written. This is how it's going to be. Maybe you don't like this administration. Hey, if you wanted this stuff to happen, now's your opportunity. Make it happen. It's your only chance. Time to grab it.
Right. And it sounds like they won't have a choice.
And this is how it's going to be. Well, no. But the point is that the executive order has a comment period till I think September 12th.
Oh, okay.
Comment period. And so this is the opportunity to dive in, go through that, make suggestions, and hopefully fix this to make it even better. So.
Excellent. Oh, I forgot to ask when you were talking about covering medications for transplant. Most of the transplant medications are now generic, correct?
And still expensive. Yeah.
Okay, so they're still very expensive despite that.
Yeah. And I want to.
You mean without insurance, they're very expensive. I guess.
That's right.
If you have some coverage, your reasonable copays for generics and whatnot.
Medicare can be rough with the donut coverage, but that change to get it covered, that has to be passed by Congress, and that has not been done. The administration has pledged support to push for it, and it seems like it's a low-hanging bipartisan issue. You hope that it gets passed, but it's sometimes the easiest things and the most obvious things are the hardest to pass.
Yeah. Though it's this tricky thing always, we're always concerned about how much, it's this game of chicken that's played between the payers, and in this case, the pharmaceutical industry, and the pawn, and really the pawn is the patients in between, and everyone says they're speaking for the patient, but if the U.S. government, with its ability to go into massive amounts of debt, if the U.S. government says we are going to cover this, that seems to automatically increase the price of whatever this is. So it's this, and you see this, and it's this problem. And I don't know, I don't know what exactly what the best solution is. I know Michelle would say that this is exactly why we don't want the government paying for medications or paying for dialysis, because that automatically raises prices by a factor of X. So do you worry that do you think about that in terms of the government says, if for tomorrow the government said we're going to pay for SGL2s, every SGL2 is covered.
I think that would be great.
No, that would be great. But who puts the bill? How much would that cost? So the more opaque you make prices to patients, it seems the higher price.
I guess I'm not worried about that with transplant meds, because these medicines are already covered for the first 3 years. It's just like, let's attach our brains and say, hey, these patients need these medications until the kidney fails. Right. Let's cover it for that long, because when it fails, we're obligated to pay for their dialysis. And so we'd much rather pay for the better solution, which is a transplant. Patients are happier and they live longer. Then why would we not pay for that and pay for dialysis, which is the worst solution?
Right. No, as treating physicians, every day, I could care less about how exactly the patient gets the med. I just want them to get the med.
I want them to get the med.
When you
That's right.
take like 12 steps back and put on this little policy hat, not that I'm a policy person, but meaning I'm not a real policy person. I just pretend to write about it. And then I think about these things in terms of, what exactly we're doing. But Joel, thank you so much for coming on. This has been awesome. Thanks for everything that you're doing. Thanks for all the commentary. I mean, I learned about almost the entirety of the EO from you tweeting furiously next to President Trump and Azar. Oh, did you get to meet him? Did you shake his hand or anything?
I did not. No, there's about 500 people in the audience at this time. I did not get to meet him.
So you did not get an autographed MAGA hat. Is that a MAGA hat behind you there? No,
that is not. It's decidedly not a MAGA hat. But
he looks around. He looks
around making sure. No, but it was.
I just checked your follower count. It just dropped by 5,000.
I'm sure. What can you do? But it was. I'd never seen the only other time I'd ever seen a president was when I graduated college. The first President Bush came to speak at my graduation, and that me and my 100,000 closest friends all got to watch him. This was a bit more intimate. It's pretty cool.
Awesome. Very, very cool. All right. Well, thanks again for coming on. Thanks for taking the time.
Awesome. Take care.
See you on Twitter, sir.
Bye.
Take care.